Welcome to High Truths on Drugs and Addiction, where national experts bring you facts and answer your questions. I am your host, Dr. Ronit Lev, an emergency and addiction doctor who has served at the White House and still practices on the front lines. Right here on High Truths, you will learn from experts, hear stories from the emergency department, and listen to people who have struggled from addiction. Friends, fentanyl is plaguing America. It has infected all illicit drugs, from cocaine to meth, counterfeit pills, and even marijuana. If you're around someone who may be using drugs, you should carry naloxone, the opioid reversal agent. Carrying naloxone for drugs is like carrying an EpiPen for allergies. If you need a prescription for naloxone, you should have one. No questions asked. That is why I am offering a free prescription to anyone who needs one. Come visit me on hightruths.com to learn more about the show, submit a question, or download a free prescription for naloxone. And if you like the show, do me a favor. Give us a 5-star review and subscribe. Your stars are very much appreciated and go a long way in supporting the program. Today's episode is sponsored by Families Against Fentanyl. FAF is an organization set on breaking the status quo of failed solutions and to get to the core of the supply chain of deadly fentanyl. Learn more about FAF by visiting familiesagainstfentanyl.org and sign their petition to declare illegal fentanyl a weapon of mass destruction. Hi, everyone. I so enjoy being with you to share another episode and another High Truths conversation on drugs and addiction. For your added entertainment, you can now watch this podcast on YouTube, something new I added for season 2. And of course, you can continue to listen to High Truths on your favorite podcast platform, as you may be doing now. You know, last year I was involved in an interesting research project that I conducted with scientists from the Center of Substance Abuse Research at the University of Maryland. The study was called EDDS, Emergency Department Drug Surveillance, and my hospital was one of 5 selected to participate from the United States. We sent 150 urine samples from patients that we ordered a urine drug screen to Maryland for comprehensive testing at a level higher than what we could do in the hospital. And the results were astonishing. 76% of all specimens were positive for methamphetamines. That's a lot of meth. And that makes us the meth capital of the United States. And it follows that San Diego is next to the Mexican border, a large supplier of our drugs. Only 6% of the urines were positive for fentanyl, and that was also surprising because deaths from fentanyl have tripled in San Diego County. We're now at 2 deaths a day from fentanyl. Very sad and very preventable, which makes it even sadder. Marijuana was present in 48% of all drug screens, as well as half of all methamphetamines and half of all fentanyls. And really, 50% of all drugs are also positive for marijuana. Our emergency department is inundated today, not just with COVID cases, but we're holding patients in the emergency department for days or weeks because of mental health problems. People are living in our emergency department day in, day out, day, night, brushing their teeth there, doing jumping jacks in the room, and probably being very bored. But many of them are also detoxifying from drugs. There's a significant intersection of both mental health and substance use disorder, and we really should be devoting more research to this field. This data is important and should be used to drive health policy. What percentage of all mental health patients simply need to detoxify from drugs and to be safe before they're safe to be discharged to the emergency department or hospital? And perhaps this data will show that we need more sobering centers or different resources in addition to more mental health beds. So I hope that we continue to study the intersection of drugs, mental health, and holding patients in the emergency department in order to drive science-based health policy. And with that, let's hear our question of the day.
Hi, Dr. Lev. My name is Annie McFarland. I'm a registered nurse case manager in a very busy emergency department. We have a lot of patients with methamphetamine use disorder, and I'm wondering if you can tell me what's the most effective treatment for that. How do we help these people? How do we really get down there on their level and help them get out of that horrible addiction? I'd really like to know.
Thank you.
Annie, thank you so much for your question and for the concern and devotion that you have to provide care to our patients in the emergency department. I appreciate the frustration for lack of resources for patients addicted to methamphetamines. And because of that, I have a perfect expert for this discussion, Dr. Brian Hurley. Dr. Hurley is an addiction physician and medical director of the Division of Substance Abuse Prevention and Control for the Los Angeles County Department of Public Health. He is the president-elect of the American Society of Addiction Medicine, ASAM. Dr. Hurley treats patients and does research as well as involved in medical education. You can find Dr. Brian Hurley's bio on the High Truth show notes. Dr. Brian Hurley, welcome to High Truths.
Thank you. Thank you for having me.
And I really appreciate it because I know you had a long day at the office seeing patients and saving lives, stamping out disease. And now here in the evening, you are with me. So I thank you for that. I ask my guests what inspired them to work on the issue of addiction. Usually I find that people who are involved in this field are very passionate. And you are a leader in a fairly new medical specialty. And I know that that's exciting. Tell us what inspired you to pursue this career path.
Well, to start off, I'm an addiction physician. And actually, I'm one of the few people I know that in the early 2000s applied to medical school to practice addiction medicine. Like I started out, I was pre-med. And well, no, actually, that's not even true. I was in college. I wasn't pre-med and I was trying to figure out what to do. But I had enough experience. I grew up in Los Angeles. I had a number of friends and people I knew who were using methamphetamine. And it was just such a devastating impact on their wellness and on their lives that I got interested. What is this drug? How does it work? And so when I went to college, I started studying methamphetamine neurotoxicity. And I learned enough about doing bench research to know that I didn't want to do bench research, right? That wasn't the career for me, but I got interested in how else to apply the science of addiction to help people. And addiction medicine just seemed like a really natural choice. So that's what led me into the field. And it was over 20 years ago, and I haven't looked back.
Brian, that's really interesting. You're right. I haven't met a lot of people who are passionate from, the college level to get into addiction medicine. For me, it was secondary. But I do know what it's like to be in a new specialty because emergency medicine was new when I went into it. And that, brought, you're kind of a pioneer at the time. And then from emergency medicine, I got interested in addiction medicine and took the boards and passed. And now really second part of my career is really devoted to that. So that's fun.
It always strikes me as curious when emergency physicians aren't interested in addiction medicine. I think it's just such an intrinsic part of emergency medicine practice.
It is, but it's very different when you're devoted to it as a specialty. Yeah. So what makes it different is my conversation with patients. It used to be, you're drunk, your alcohol level was 300, stop drinking.
Yeah.
Now I'll try to use like the motivational interviewing thing.
Sure.
And, how can I help you? How is this affecting your life? These kind of conversations I never had before I got into addiction medicine. And it makes it a lot more rewarding, actually.
It sure does. Motivational interviewing really changes your relationship with patients, right? Because you don't feel, at least for me, I don't feel like I have to fix people. My job is to guide people when they're ready. And it's a very different experience of practice.
Yeah. It does. It's helpful and we'll talk about that. So I want to talk to you today about various types of drugs and then the priorities that the American Society of Addiction Medicine has. But let's start with methamphetamines. And Annie McFarland, she's one of the case managers who works in our emergency department, a very busy place. She sees many, many, many patients who are homeless, who who are using methamphetamines and is frustrated by the fact that there is little resources of what she can, what can she do for these patients. So you hear that frustration in her voice. So I told her, we have the best person here to answer that question, and that's you. What can we do?
Sure. First of all, methamphetamine, as drugs go, is on the more destructive end of drugs, right? So there are some drugs that are not as addictive as other drugs. There's some drugs that have fewer physiologic consequences for other drugs. Methamphetamine has sort of like everything that's worse across the board. It's extraordinarily addictive. We don't have any super high efficacy treatments. We have effective treatments, but there's nothing that's like a silver bullet, right? There's no like one just, take this med or do this therapy and everything's fine, right? The treatment for methamphetamine use disorder is iterative. And then with the methamphetamine marketplace being increasingly saturated with fentanyl, we're now seeing opioid overdoses for people who are using methamphetamine. So all of these is just, it's a perfect storm of methamphetamine related problems. And as with all addictions, there's medication, there's counseling, and there's support. And methamphetamine happens to have no medications which are FDA approved, but that doesn't mean that there aren't medications that can be helpful. So the medications that can be helpful for methamphetamine use disorder include medications like mirtazapine, which goes by the trade name Remeron, or bupropion, which goes by the trade name Wellbutrin, particularly in combination with naltrexone, which goes by the trade name Vivitrol. So there is some evidence that these medications can help. They help. They don't necessarily make everyone that takes them stop using. So I don't want to oversell them, but they can be a helpful component of a treatment plan. And then there's counseling, all right? And as counseling goes, there's a myriad of counseling approaches that have some efficacy, but probably the strongest effect is on contingency management. The state of California recently got approval from the Center for Medicare and Medicaid Services to use Medicaid money to pay for contingency management for people with stimulant use disorders, recognizing the need for this kind of treatment. And contingency management is where you take patients who use methamphetamine, and each time they evidence not using, right, usually through a urine toxicology test, you give them an incentive. And the incentive can be monetary, the incentive can be a privilege. There's a whole number of ways that you can operationalize incentives. And then the last thing that seems to be important for people with addiction, and we don't usually think of in healthcare, but is really important, are the social determinants of health. It's much easier to recover from your methamphetamine use disorder when you're housed and employed and have transportation, right? And have a community of people looking after you. And those things can be hard to immediately put into place out, from the emergency room or, from an outpatient clinic, but are a really important component of recovery.
And so you mentioned medications, contingency management, and, behavioral
support.
Therapy and support. Medications, do you use that on every patient? There's no FDA approved medications.
Correct.
Right?
So this is all off label. So just to be clear, these are medications that are FDA approved for other reasons that I would use outside of their FDA label, because they've shown some evidence and some research studies to be helpful for people with methamphetamine use disorder.
Are you finding that helpful in your practice?
I am, with a caveat, right? Most patients that take these medications don't respond. Now, that doesn't mean that no patients will respond, but if I was to be just a doctor working in the community, and my expectation was this medication was going to make a difference, I'll give you like an analogy would be, if I give you a antihypertensive blood pressure lowering medication, my expectation is it's going to lower your blood pressure most of the time. Not every patient, not every time, but most of the time. The medications for methamphetamine use disorder work in some patients. We don't know which patients respond or why. But so my practice is, I understand that most patients who take medications for methamphetamine use disorder are not going to immediately become abstinent from methamphetamine. But I also know that there's a subset of patients that will, and that's what I'm aiming for. I'm trying to give my patients every opportunity to be able to bring their methamphetamine use disorder into remission.
I just had a funny thought.
Mm.
It's like giving Flomax to people with a kidney stone. Is it really going to drop your kidney stone? I don't know. But
That, you know, and we do with things like that all the time in medicine, you know,
Right.
where we sort of give something, well, it might help.
Right. The studies I think that you're talking about with Remeron is like 14%. It's pretty poor.
Yeah.
But it's like, hey, I'm going to give you the 14%.
I'm shooting for the 14%. That's exactly right. And even with that thing with Remeron, like if you have a poor appetite and you have difficulty sleeping and you have some depressive symptoms, you know, in other words, it's not just the methamphetamine. I can rationalize it looking at what are the medication's other effects, right? So if somebody drinks a lot and uses methamphetamine, that makes naltrexone all of a sudden a much more attractive option, because now naltrexone can help both address the excessive alcohol use and potentially help somebody use less methamphetamine, particularly if it's in combination with bupropion.
Right. I just don't want people who are listening to say, hey, you have a patient with methamphetamine, how come you're not putting them on Remeron? It's like, wait.
That's exactly right. There's good reasons not to, right? On the other hand, I don't think it's wrong to put a patient on Remeron, right? Like it's a somewhat nuanced conversation, and with all things, I would only do it if the patient was agreeable, because there's patients that just they don't want to take meds for whatever reason.
And I'd say for you as an addiction medicine physician who has follow up with their patients, you know, your patients are established or becoming established, that would be fine. But for me as an emergency physician, like, here, have some Remeron. Like, I don't think that we're not there.
Well, you know, it's interesting. I have colleagues that work in emergency medicine that are much more aggressive about Remeron or, you know, naltrexone, let's say. Typically, those are practices where patients get linked to close follow-up, right? Yeah. So it isn't necessarily that the emergency physician will be doing the follow-up, but that there's a plan for follow-up with the patient. And it's true, I have a continuity practice, and that means I can be iterative and try one thing. If it doesn't work, try another thing, right? Whereas in emergency medicine, typically it's during the visit is what you got, and you hope for the best when somebody just gets discharged.
Right. And we talked a little about contingency management and state of California now being able to do that. That's a huge win. I'm sure there's a lot of organizations who went to bat for that. And I think that's something to celebrate, that we've got a new tool that we didn't have before, and it's fresh, hot off the press. And how is it being implemented? What are you seeing? It's not easy to do, but are clinics starting to do it?
Yeah. So one of the big hangups with contingency management is how to get it paid for, because you couldn't find a health insurance product that would do it. So the fact that Medicaid will now pay for contingency management for Medicaid beneficiaries is at least the Californian Medicaid beneficiaries is, I think, a huge win for the state of actually finding a sustainable way. So historically, contingency management, the way it worked was you got a grant. The grant paid for the contingency management program. The grant ran out, and the program stopped, right? So all the patients that had achieved whatever gains they got during the contingency management program, you know, when the program went away, that component of their recovery ended up being lost. So now there's a sustainable way of paying for it, which is great. It actually goes live in July, so it's not live today. So one of the jobs I have is the medical director of the Los Angeles County Department of Public Health Division on the Medicaid substance use program. So one of the things that we're doing in Los Angeles County, but each county in the state is making these decisions, is how fast do we want to roll out contingency management? If so, who would provide it in our systems of care? You know, which of our contractors or directly operated programs would run a contingency management program. So we're very much in the planning phase. But just to be clear, California's contingency management program is built around the outpatient treatment system, like methadone clinics, outpatient addiction treatment programs, day treatment programs. It's not yet built or available to community health centers, emergency rooms, hospitals, street medicine programs that aren't otherwise registered with the state to provide specialty addiction treatment services. So it is at this moment very much a pilot, but a pilot that the way the state's operationalizing it is they want to make sure that the people that are getting the contingency management benefit are also enrolled and getting other components of addiction treatment to maximize the chance that it will be successful and potentially generalizable outside of those settings.
Does that mean that starting in July in California, we should send, as far as Annie's question, we should be sending our patients to the methadone clinics for methamphetamine use disorder? Well, we used to be sending them.
Yeah, that's a great question. I mentioned methadone clinics because they're one of the places that are able, right, to take advantage of the continuing management benefit. But you can't go to a methadone clinic unless you have an opioid use disorder. Just to be direct about that, right? They treat opioid use disorder now. Plenty of patients with opioid use disorder have stimulant use disorder, right? So methadone, you can send a patient with opioid use disorder and stimulant use disorder to a methadone clinic. But because of the way the pilot's rolling out, I would also just, fair warning, not every place that does addiction treatment funded by Medicaid is going to be participating in the pilot. So you'd want to confirm in advance which are the places that are offering contingency management. So one of the, operational issues I'm working on is how do we make in LA County the programs that are offering this treatment visible so that people know where to send patients that they think will benefit.
Well, that's important. I'm going to start doing that in my area, and I'm wondering if we need to do this in a systematic way all over California. Like I'm thinking of our emergency departments. Like every emergency department in the state should know where their local clinics are to refer patients.
Agreed. Without substance use navigation, a typical referral, like here's a sheet, good luck, generates virtually no follow-up. It's not never, and the follow-up gets much better if you start buprenorphine in a patient with opioid use disorder, just as an example, right? But but for kind of a straight, uncomplicated methamphetamine use disorder, the best practice is to have that patient meet with a substance use navigator that would help follow up with them, right? So best practice meets in the ER and then, actually meets them at wherever their follow-up is or connects with them on the phone or, does whatever service navigation is necessary. So I think a list is critically important and substance use navigation is also critically important.
Right. Or all our case managers that we all have case managers in our emergency department. They're informed and at least, there's something that we could be doing or referring to. I'm looking forward to that. I'm excited about that.
I'm excited about it too.
We talked about motivational interviewing. That's something that we could do for people who are using methamphetamines or any type of drugs or really for obesity or diabetes or high blood pressure. Really, it works for everything. It probably works for your children and husbands and wives. You do a great course on that.
My husband will oftentimes tell me, "You're doing that motivational interviewing thing."
Right. I need to do that more on my husband. It could help me get the groceries out of the car. Right. So tell us about that. What are some key principles and learning more about it?
So motivational interviewing is defined as a conversation style, a collaborative conversation style, focused on change. And it's structured in such a way where the interviewer structures the interview such that the patient or the interviewee is the one that gives a voice to change. And it's really counterintuitive. We don't learn this a lot in medical school, right? In medical school, it's ask a bunch of questions, get your, everything you need to know to write a note, do a formulation and come up with a plan, then come up with a plan and tell the patient what the plan is, right? That's my back of the envelope of what I remember. What motivational interviewing does is actually say, start with open-ended questions, and then listen for what is the patient ready to do, right? Because motivational interviewing isn't some trick to get a patient that's not ready to change, but they can take a patient that's ambivalent about change. I'll give you an example. A patient walks in, I think you used an example earlier. Patient walks into the emergency room with a blood alcohol level of 300. And rather than saying, you can't drink, you might say, what about that alcohol, huh? You end up in the ER. And just use some very basic observations and reflections to see what the patient says next. And the patient will almost always defend themselves. I didn't drink that much. It's not my fault. But then the patient will also sometimes give change talk. And change talk, it would be something like, I can't believe how much I drank. This is terribly embarrassing. I can't believe I'm in the emergency room. Like, what has the drinking done to me now? And in a strong motivation interview, you use reflective listening to selectively reflect the change talk. So you might hear sustained talk, and rather than challenging it or arguing with it, like, you don't think you have a problem? What are you talking about? Rather than confronting it, you what's called roll with it. You roll with sustained talk and then listen for, you end up in the emergency room. That's really scary. right? They didn't say that, but that might be the underlying sort of thing, that the message that they offer. And then and see what they say next. And oftentimes you get more of what you reflect. So if you listen for change talk and selectively reflect change talk, you're more likely to have the patient give voice to the changes they might be ready to make. And the empirical studies are that us clinicians talking about change makes no difference to patient readiness to change, right? Our arguments, our reasons, our ideas are themselves ineffective absent the patient also giving voice to them, right? The patient behavior so much more closely tracks with what patients hear themselves say as opposed to what the clinician says, that I try to structure essentially all of the interviews that I do. I try to structure and listen for motivational interviewing until I'm clear what the patient's ready for. And then we go to planning, but that's, in this case, I know that the patient's on board with the plan because of what they've given voice to. So I could go on and on about motivational interviewing.
Yeah, it is. And I think you do an 8-hour class, which is, it's wonderful. That's the one thing I wish they did teach. And I tell everybody, I have 2 daughters in medical school, that if they were able to get that in medical school, I think that would be a good life and physician skill. I give motivational interviewing trainings a lot. And I have a trainer that I train with. He says, what if instead of getting paid per unit of service, right? So per, DRG code in the hospital or per CPT code in outpatient practice, what if we got paid every time the patient gave us a change statement? Right? How would that change our practice? Yeah. That would probably change things pretty quickly. Give them the script. I just thinking, it made me think of all sorts of interesting things, but I think we rarely get thanked in the emergency departments for what we do. We just kind of see a lot of patients and it's all a blur. The one patient I had that brought me flowers like months later was a guy who was drunk, and I just kind of described to him what he was like and told him he seemed like a nice person now, but when he was drunk, he really wasn't. And that was his change. Then he made amends and thanked me for it months later. By the time I already forgot about him.
It's so interesting you say that. One of my mentors, Shelley Greenfield, Chief Academic Officer at McLean Hospital at Harvard Medical School, says as a medical student, she was in the emergency room. Patient came in drunk, right, intoxicated. She explained, you have alcohol use disorder, right? Here's your treatment. This is a medical condition. Here's your treatment options. And it's her story, so I'm probably not doing it justice. That patient came back and brought flowers, or I think the patient's family member came back and brought flowers. Like, there is something about these intense interactions with the emergency room that can.
Yeah, it's an educational moment for sure, and for a lot of things. Can you mention something about the trifecta? We've talked about this before. The trifecta of homelessness, mental health, and methamphetamines. And we're in California. We're seeing 50% of all the unsheltered homeless people in the entire United States live where we live in Southern California. And the number has increased during the pandemic. I swear people are just being bussed over here. They're not native Californians. But anyway, we have this trifecta of a problem.
We do have a concentration of people experiencing homelessness. And partly because, substance use is shaped by geography, right? Drug use is typically a very local activity. It's hard to use drugs virtually, right? So there are trade routes and cartels, and there's a lot of things that happen in the illicit marketplace that factor into what drugs people use. So there's a lot of people experiencing homelessness in Los Angeles, and there's a lot of people experiencing homelessness, or I should say Southern California, right? In Southern California. And in Southern California, they use methamphetamine. It's outside of tobacco and alcohol, one of the top drugs. It's actually overdose, and methamphetamine involved overdose is one of the leading cause of death for people experiencing homelessness in our area. And roughly half of those deaths are opioid overdoses, if you can believe it. So fentanyl, right, which is can be found contaminating methamphetamine, is a huge driver of overdose. We've seen that nationally since 2014, and then locally since maybe 2016 or 2018, depending on how you slice the data, of fentanyl being a huge driver of overdose. And the other thing about methamphetamine is that so methamphetamine in some ways it's a solution that becomes a problem worse. Like if you're looking for something to keep you awake and alert, say at night when your safety is at risk, like there are some some understandably adaptive things that I can see why people experiencing homelessness that use methamphetamine find methamphetamine to be adaptive beyond just the euphorogenic effects, right? Beyond the sort of high you get. But I'd also say that methamphetamine can cause psychosis. You get after intoxication depressive states, even outside of psychosis, a lot of agitation. And what I've seen, and my primary board outside of being an addiction physician, I am a psychiatrist. And, and work in the psych emergency room, among other places. But a considerable number of patients that come to the mental health system's attention are therefore methamphetamine consequences. And it's sort of counterintuitive because you think, oh, well, if it's methamphetamine, you should, go off to treatment. But it's oftentimes the mental health system that is dealing with the acute effects, right? The acute agitation, the suicidality, the psychosis, right? The other psychiatric effects of methamphetamine use that do pass when the methamphetamine use passes, but require a fair amount of psychiatric attention and resources. I'm thinking I worked on January 1st in the emergency room, and over half of our beds were for people that had needed emergency room attention for their methamphetamine intoxication, and we were essentially waiting for the effects of methamphetamine to wear off to make a decision.
We call it methacidal.
Yeah, that's right.
Right. They have methamphetamine exactly right. Toxicity plus suicidal or methacidal. And the problem is, if you're drunk, that'll last a few hours, then you'll be fine. We have drunkicidal too, but methacidal takes 3 days.
That's exactly right. That's exactly right. And I'll tell you, having worked in inpatient psychiatric units and in the jail, right? People will go to like the mental health housing when they get incarcerated and then be cleared a few days later, right? And then they can go to general population. You'll see people end up in a psychiatric unit on a 5150, a 3-day involuntary hold, clear, and then be discharged. So our mental health system is really faced with managing a lot of the mental health effects of methamphetamine.
Yeah, you know what? That was my intro to this episode is that we need to get the study and data of the intersection of mental health and drugs, because maybe that data shows that we need sobering centers. Maybe these patients, a significant, not all of them, need a place to detoxify and get their brain back. Rather than the emergency department.
Yeah, for sure. It's interesting you mentioned that. There are sobering centers. And in fact, the state of California the health plans are beginning to covering sobering centers. I'm working with one of our local health plans. We're creating a sobering center in South Los. We already have one in the Skid Row area of downtown LA, but we're opening one in South Los Angeles. The kind of standard best practices on sobering centers are 24 hours. Like sobering centers are built for alcohol, at least historically built for alcohol.
Right. All right, but now we need them for meth.
Right. And so I'll just say the sobering center model for methamphetamine is much less consistent because I'll tell you, there are a lot of patients, they're not stable enough for a sobering center, right? Sobering center requires somebody to be like calm, participating, voluntary. I mean, you can be drunk and do that, but if you're hallucinating, if you're, acutely agitated or aggressive.
Yeah, you can't do it in maybe the acute phase, but the crashing phase, the 3-day phase.
Where people just need a place to sleep. Sure.
Mm-hmm. Yeah. So you mentioned high association of methamphetamine and fentanyl. Mm-hmm. It's why we're really advocating now for people using fentanyl or any illicit drug to have an naloxone, because you don't know. It's Russian roulette when you're using drugs, what can have fentanyl in it. So it's really a travesty. And the Families Against Fentanyl were the first to headline the CDC data showing that the number one cause of death in the age 18 to 45 is fentanyl, more than COVID, more than suicide. And every 8.57 minutes, somebody dies of fentanyl. So really, with the Omicron variant, people get sick with COVID now, but they're not dying as much from COVID. They're dying from fentanyl. People are dying from fentanyl. What can we do?
Fentanyl is a huge threat to public health. Let's just be clear about that, right? It's a huge threat to public health. So a couple things. The population that's highest to use fentanyl are people with opioid use disorder, right? People that are buying heroin or, illicit prescription narcotics. So that population still uses fentanyl the most. The most effective treatment for opioid use disorder are medications for opioid use disorder, particularly methadone, buprenorphine, and naltrexone long-acting injection. And when taken, these medications help reduce overdose. So I would sort of start with we want to make sure every patient with opioid use disorder has access to medications for opioid use disorder as quickly as possible. That means even before they're ready to go to a treatment program, maybe even before they're ready to stop using fentanyl, because it can dramatically reduce the fentanyl driver of death. That said, there's a lot of people who, there's innumerable groups that describe the experience of people that go by another drug, methamphetamine, maybe a knockoff sedative like a street like Xanax or something, and there will be fentanyl laced in it, right? And people will overdose unknowingly. I think Narcan should be in the hands of every person in the United States, right? And we should know how to recognize the signs of overdose and immediately respond to overdose. And so naloxone or Narcan is an antidote to opioid overdose. It's temporary, but it can be the difference between somebody staying alive and not staying alive. And then the third thing is help reduce drug use, right? So, and now we're back to social determinants of health, which would involve, making sure that people have access to treatment as soon as they need it, make sure that people have access to housing, make sure that people stay employed as long as possible, right? Trying to reduce the community burden of substance use.
I was hoping you were going to say prevention, primary prevention, like, teach resiliency in elementary and middle school so people don't get into drugs in the first place.
Yeah, there is some research on resiliency that tends to work really well when people have adequate resources. So one of the things that I have seen not work is resiliency training in under-resourced communities where it's hard to do, strong engagement or resiliency if you're not housed, right? Or if you don't have control over your living conditions or your working conditions. So I think that there's a component of resiliency training, which is an individual's sort of responsibility in navigating the world and all of its unfairness. But I also think family systems and communities need to think about how do we make sure that we're not leaving an under-resourced community and then blaming them for the consequences of their own under-resourcing. So that means community housing programs, supportive services. And I think both are important, right? In teaching individuals, right, resiliency skills, but also providing people reasonable access to how to live lives free of drugs.
But, and then I don't know the answer to this, but the overall population that's using drugs, there's a small percentage, they're not the majority, I don't think, that are unhoused and have those constraints. The majority probably did come up with housing and maybe other trauma, but that's why I think starting at a young age and not doing that primary prevention work is so important.
Our state Surgeon General is recommending adverse childhood experience screenings, right? Because it's not simply unhousedness, right? It's all of the traumas that one can experience growing up related to disrupted attachments, disrupted safety. I mean, it's more than simply housing, to your point.
So I think one of the projects I've been working on over the past year that's coming to fruition, I think as of tomorrow, we will have a California bill by Senator Melissa Melendez requiring all hospitals to include fentanyl in drug testing. So all urine drug screens in general in the United States have the federal 5, a minimum of 5 drugs that's screened for. In San Diego, we kind of piloted this over the past year. Now the majority of hospitals in San Diego include fentanyl in their drug screens. And now we're hoping all of California hospitals would have that and be a model for the nation. And a positive screen lets the doctor know, lets the patients know, let friends know, can change behavior, can inspire a prescription for naloxone. So I think that's a big deal. I'm really excited about it. And I hope ASAM and you support that bill when it comes out. CSAM, the California Society of Addiction Medicine, would be the one to take a position on the California state bill as opposed to ASAM. But what I can say is, in my clinical practice, I use a 14 panel, right? I like to know a whole variety of things. That may not be practical for routine medical practice, right? So I'm not trying to but you don't get those 14 drugs right away, right? You send them out. No, I have a 14 panel cup immunoassay. That comes back within an hour? It comes literally, I have the cup in my hand. It comes back usually. Oh, very nice. And it has fentanyl. So there's no FDA-approved fentanyl strip. So I could use one illicitly, or it's for forensic use only. So I could use that.
That strip is notoriously unreliable. Otherwise, I would have to send it to a lab.
Which is why this bill is so important, because if we're doing that in the hospital, then you have it on the outpatient setting because you don't have access to that testing.
I don't. And so that's why it's so important for me to have access to fentanyl testing that's hospital-based or lab-based. And I need to know that the labs have the capacity for running fentanyl. So that's a long way of saying I certainly personally support the bill. ASAM doesn't traditionally take a position on state legislation. That's usually our state chapters. And as a CSAM member, certainly would support CSAM taking a position in support of the bill, because we do want to be able to identify fentanyl use.
So once I have a bill number, I'm going to send it to you.
Yeah, let me know. I'm happy to talk about it.
Yeah. That'll be great. I'm excited about that one. On the supply side, I think supply is not something in the doctor control. Like, what are we're not involved in that, but there is an organization that's sponsoring this episode, Families Against Fentanyl, who are looking on a high level to declare fentanyl a weapon of mass destruction, and that way to have increased penalties to the people who are bringing it over with their precursors or sending it from China to Mexico and bringing it over on a high level. People who are doing that are really murdering Americans. And we need stiffer penalties for people to think twice, 3 times, 4 times before they bring such drugs like that into our country. And then I don't know what you think, but I've been promoting the infectious disease model for overdoses. Like we're doing all this stuff for COVID, and we've got hotels for Shigella diarrhea for 6 cases. Yeah. Why aren't we doing more for that? Why aren't we doing contact tracing for overdoses? Each overdose is a teachable moment. And I think we can apply the infectious disease model to drug overdoses. You
use the word the infectious disease model. It's interesting. I sort of think about it as the public health model, right? Of epidemiology, tracking, and prevention, right? Yeah. And I'm a huge fan of the public health model of addiction, right? In concert with treatment, right? I'm not saying instead of, right? But yeah, of course, because we know that fentanyl pops up geographically. So it pops up in clusters, and we know that people generally have associations with who they use with. So I think that infectious disease tracing, or public health epidemiologic model of addiction, has a lot of promise. It's tricky, when people get an infection, there's not usually a lot of legal consequences, whereas historically, our country has treated substance use as a crime. And so I think there's people with very justifiable concerns. If I talk to this contact tracer, right, if I'm honest about my substance use, am I going to get into trouble? We would need to work through that stigma, because for very justifiable reason, there's a lot of people that use drugs that don't trust the government or don't trust people that would call and ask them about it, whereas they might for COVID.
Yeah, so I would do it a little differently than an STD. So for mapping, frankly, we should have mapping. There's many states in the United States that have mapping for overdoses. We don't have that in California, and we're behind. And we should be doing that, because we'd say, okay, this zip code, we need like naloxone boxes on all the bathrooms and the gas stations. And this is, we would be smarter in our harm reduction approaches if we
deployment.
If we had
think about it like AEDs, right? Like if you're ever in a public place and somebody is down with an arrhythmia, you have a device that could save them. It doesn't always, right? But could save them. Where, think of the same model where, how many units of Narcan do we need where are they being deployed? How do
we, and yet we're afraid to do the mapping. And we're able to, because we do it for STDs, we do it for COVID, and why aren't we doing it for overdoses? And contact tracing, I see, would be different. It'd be like, okay, I do it in my own like little personal practice, just kind of to see how it works. Like, you had an overdose. Who else is using these drugs? Who else got these pills? Let's tell them and let's get rid of it, so that nobody else dies from these pills, right? Yeah. It almost killed you. So in that kind of sense, and I've had, or like the 2 girls went to a hookah bar and they thought they were using cocaine. They ended up using fentanyl. They came from this college. Let's go educate, right? Mm-hmm. Every overdose is a teachable moment. That population is now going to go. Yeah, that's kind of what I mean by
every overdose is a teachable moment. It's a great frame.
Yeah. All right. So let's talk about marijuana.
Sure.
California declared marijuana an essential business during a pandemic. They now are giving tax breaks to the poor marijuana industry. While their business boomed and other businesses have suffered, but where's the science there? What are we doing right and wrong on marijuana?
Well, the voters in the state of California voted to essentially create a cannabis industry, and that's what we're seeing. There are a number of players in the industry, right? Companies who get a lot of market traction by talking about the health benefits. And I think part of that was the campaign that really, in the 90s, we the state of California authorized people that had received a card from their physicians to be able to possess a small amount of cannabis without prosecution. And it's interesting. People talk about a marijuana prescription that doesn't exist. You can't. It's not a prescribed. I mean, you can prescribe. There are FDA approved cannabinoids that are prescribable, but the actual plant, a thing that people that sort of exploding across the industry, has never really been prescribable. So you can give a card to protect somebody from criminal prosecution, but we still see this idea of sort of the medicinal benefits of cannabis. And the evidence on the medicinal benefits of cannabis are actually quite soft. It's not that there aren't any benefits. For example, cannabidiol seems to have an effect on certain types of juvenile seizures. But
we have a prescription for that.
Right.
But babies are not smoking pot.
That's exactly right. And so what I've actually seen is strikes me personally is like a snake oil industry, right? Like if you can't sleep, cannabis. If you sleep too much, cannabis. If you're depressed, cannabis. If you need to
if you have COVID, you should use, cannabis.
Absolutely. It's sort of it's a good for what ails you. And it reminds me almost of the tobacco industry back when the tobacco industry used to promote tobacco as healthful, right? And it's been, many decades since the tobacco industry has done that. But I think we're seeing the cannabis industry go through a very similar evolution right now.
Yeah. Same playbook, but better.
That's right. Now, I also recognize the tremendous societal costs of incarcerating people for using cannabis, right? And I think there are cannabis advocates that very rightly point out that criminalizing people and incarcerating them for possessing small amounts of cannabis may cause more harm than good. I think that there's a point there.
But it's not fair to marry those two issues. You can tell the truth and health benefits and decriminalize it.
I agree. I agree.
Interesting. It's always, thank you for, a lot of people don't want to talk about the M word, the marijuana word, but
I'm happy to talk about cannabis.
And, I think right before this, I shared a recent study. We saw what's happening to kids, not kids, babies. Or one study, 13.3 fold increase in children under the age of 6 who are coming to the hospital because of marijuana poisonings, and 15% of them are going to the ICU. So, they see these little Cheetos. They look like Cheetos, but they're Weetos, and they end up in the ICU. It's so sad. There's
this idea that cannabis is benign.
It's not okay to be preying on children.
And it's not, yeah. Delta-9 THC is the dominant cannabinoid that people known for its euphoric effects. But there's actually a number of Delta-8 THC products that currently are available legally in the market. And one of the things that we're seeing is an increased rate of youth exposure to cannabinoids that aren't actually driven entirely by Delta-9 THC, but by this variant that people can actually purchase, and it's currently unregulated. So I think that with the huge rise in the availability of cannabis and all of the health consequences that we see sort of resulting from that, I have a feeling we're poised to see some regulation around cannabis. I don't know exactly what it's going to look like, but around creating some real boundaries around
we need to do that. Colorado did. The Colorado mothers have rallied about the high potency and protecting kids from this. And they've done something. California has not done anything since legalizing marijuana recreationally. And I think what people voted for and what is being sold today are completely different things. This is not what people voted for. Yeah. These really high potency products that are resulting in significant, every single shift I take care of a marijuana poisoning.
Yeah.
So
you make a good point. Marijuana is not entirely benign, no matter how much people claim that it is.
Yeah. And a huge amount of marijuana-induced psychosis and other health benefits. One of the organizations that started, I don't know if I shared with you, is called ISAC, the International Academy on Science and Impact of Cannabis. And in it, I put together a medical library of the various reference, peer-reviewed scientific publications on health effects on the heart and brain and GI system, and kind of going over, there's thousands and thousands of articles. I don't have even the majority of them, just key ones that I put together for people to be able to advocate.
Sounds like a vitally important resource.
Yeah. I'll send it to you so you could check it out.
Yeah. Look forward to it.
Brian, you are the president-elect of ASAM. Congratulations.
Thank you.
And what are the priorities for ASAM?
Well, so ASAM is the American Society of Addiction Medicine. We are the physician-led professional community for those that prevent, treat, and promote remission and recovery from the disease of addiction, and to provide resources for continuing innovation, advancement, and implementation of addiction science and care. So that's the tagline. ASAM's vision is a future where addiction prevention, treatment, remission, and recovery are accessible to all and profoundly improve the health of all people. So we recently adopted a 3-year strategic plan that starts this year in 2022. So our overarching goals are to grow and strengthen involvement in addiction medicine. One of the things that you and I talked about up front is it always struck me when more emergency physicians weren't involved. I think addiction medicine really wants to be the source of professional development, knowledge, information, and support for the whole variety of physicians that see addiction, because any physician that sees patients with addiction. We want to be the home for support and knowledge around that. We want to expand access to addiction medicine, including reducing criminal legal system interference with the delivery of addiction care, championing addiction medicine access for all, supporting research for education, prevention, and treatment. We want to set the standards for high quality and evidence-based care. One of the questions I get asked all the time is, my family member has a substance use disorder on X, let's say methamphetamine, right? What's the best treatment? I say, actually, the best treatment is to get an evaluation, and that evaluation can help figure out what are the treatment planning components that would be important, because it depends upon a lot more than just what substance somebody uses. So ASAM has something called the Asam Criteria. It's modeled on a 6-dimensional assessment that then maps addiction out across 4 domains of care. And so I think we no longer think of the treatment for addiction as being, meds versus counseling, or, these kinds of patients need cognitive behavioral therapy, and those kinds of patients need motivational enhancement therapy. The way we think of it is as a medical condition, right? Somebody comes in with heart disease, there are certain markers that mean you need to be in the hospital. And there's certain markers that say you can be discharged and managed on an outpatient basis. Same thing's true with addiction, right? There's certain factors that would mean you need to go to a higher level of care, and certain factors where you can go to a lower level of care. And the ASAM criteria also then can be useful at looking at the components of treatment that will be effective. We want to educate the addiction workforce and our patients. We think addiction is not well understood in the community, so it's not just medical clinicians that's ASAM's focus, but we also want to be a source of information, evidence-based, reliable information for the public, and then maximize our operational effectiveness, as we all do with all organizations. We're on a balanced budget, make sure that we're continuing to grow and thrive as an organization. So those are ASAM's focus for the coming 3 years.
I like it. Well, I want to say thank you to ASAM because I took the courses and it helped me pass my boards. So I thank you, ASAM. And then I would also, I didn't quite hear, I was listening for it, the dream when I was at ONDCP that we really advocated for was having addiction medicine services in hospitals. So if you have a patient coming with endocarditis because they're using intravenous drug use, they're going to get, infectious disease consult, a cardiac consult, hospitalist service, intensivist service, all sorts of consultations, but no one may get to the source of what got to them in the first place. So we have palliative care services for people who need an addiction medicine team, like in every major hospital in the United States.
I couldn't agree more. It's one of our sub bullet points, but if you work in a hospital, I can understand why you're listening for that. We put that under our access goal. And every hospital should have an addiction medicine service. Every outpatient primary care practice should have an addiction medicine consultation, if not like a local team of, either addiction-informed behavioral health clinicians or SUD counselors. Every street medicine service, specialty service. I think that addiction is widespread enough that we need to expect every system of care to identify addiction, treat addiction within our scope, right? I'm not suggesting emergency rooms have like residential addiction treatment programs in the back, although it would be provocative if they did, but to route the patient to the appropriate level of care as feasible.
To create those partnerships in the community
And historically, the addiction medicine treatment system has stood alone, away from the rest of medicine, right? Staffed with different types of clinicians, regulated differently, funded differently. These are the sorts of divisions that make it harder for our system to be more integrated and be more effective for the patients we serve.
All important. Brian, anything else you want our audience to know about?
Recovery is possible. I think that sometimes we see, gosh, methamphetamine is, endemic, and gosh, we're in the middle of an overdose epidemic, and we are, right? The public health threat to overdose is as high as it's ever been. We saw more overdoses in 2021 than at any other point in U.S. history. So I am not going to detract from that. But we have tools. Recovery is possible. And what I can't tell you how many patients come into my office and I say, Dr. Hurley, I feel broken. I feel ashamed. And I think you have a substance use disorder. Help is possible. Recovery is possible. So that would be one of the messages I would want to put out there is if you're suffering with an addiction, if you're a friend or family member, if you're working with patients that have addiction, that there's not always a silver bullet, but recovery is always possible. And the thing that is I don't give up. I don't give up on my patients. I don't give up on my community. I still keep chipping away at it.
That's beautiful. That's beautiful. There is hope, and there's a brand new world. Addiction is a chronic relapsing disease of the brain, and as it's treatable, and there's 20 million Americans living in recovery as proof that it's possible.
That's right.
That's right. So thank you for that. And I want to say thank you to Annie McFarland. Annie, you are a miracle worker in our emergency department. We call you to help on the seemingly impossible. The emergency department is the front line of society's problem. And so we need you 24/7. You saw cases of people losing their car keys or home keys. They can't get home. They need to get their cat and they don't want to come in the hospital. And we're going to figure that out. And family doesn't want to take a patient home, and the pharmacy won't fill the prescriptions, and all the problems. You do magic to solve them as much as you could. And I really thank you for that. And thank you, Dr. Hurley. May you have the best of luck as president of ASAM. A lot of good work ahead for the organization, for our country, for our patients. And we really appreciate your education, leadership, dedication to a population that really deserves second chances, and a new generation of Americans that deserves less of a potential of a preventable disease. So I really wish you a lot of success in your presidency, in your career, and really thank you for that.
Thank you very much. Thank you for having me.
Thank you for listening to High Truths on Drugs and Addiction, where national experts bring you facts and answer your questions. This week's episode would not be possible without the generous support from our sponsor. A sincere and warm thank you to FAF, Families Against Fentanyl. Visit familiesagainstfentanyl.org and sign the petition to declare illegal fentanyl a weapon of mass destruction. Make drug dealers think twice and 3 times before peddling killer drugs. Our producer is Dave Rivas from Davey Boy Productions. I am your host, Dr. Ronit Lev. We hope we brought your day a little bit more high truths.